Good day, everybody. Today is June 18th, and I am so not happy about making this presentation because I really was hoping that on July 4th I would get to see you all again and spend time with you at the conference in Arizona. But obviously, due to the situation in the world and especially in the country, we will be doing this virtually, so I agreed to just at least speak to the members of the association and the members of this group and the parents and families and caretakers about a couple of issues in AMC and arthrogryposis and discuss some of the advances or some of the changes we've made over the year. I think the number one thing that I've found in my 5 years at Paley Institute and something I've really been stressing is that we need to increase the motion of arthrogryposis. We need to find a way that this is a stiff disease, right? It makes joints very stiff, it makes you weak and stiff. So the last thing we want surgeons or doctors or therapists or cast people or anybody else to do is make people more stiff or make people who have this condition stiffer, whether it's in the elbows or the legs or the knees. So I think that my entire goal now of my career is to restore motion in arthrogryposis and function, both of the upper and lower extremities. So it's not just about making a joint straight, it's about increasing that motion, maintaining that motion, making that strength and motion functional. So that takes a team. It takes a team of physical therapists, it takes a team of occupational therapists, of surgeons, of child life specialists, and all the support, social workers and all the support group that are needed to get children and adults through this condition to be the best functioning that they possibly can be. And I've heard many people give up and say, well, there's nothing you can do. It's just too far gone. And I just don't think that's true most of the time. So I spent the first couple of years working on the lower extremities and the knees and the hips, and I think we're really making great progress in avoiding stiffening the joints, in avoiding the external fixators and maintaining the motion of the knees, and increasing the arc of motion, which we'll have a paper coming out later this year in a journal describing our results of our first 100 knees that we've done that for. I wanted to spend some time today discussing the upper extremity, which I think is somewhat ignored. The upper extremity is very difficult in AMC, but I think we have to think about a number of things when we think about the elbow, the shoulders, the wrists, and the hands. First of all, does the patient or does the child or adult have grasp? Can they grasp something with their hands? Because that's very important, because why are we going to do so much intervention if there's not even muscles enough to grasp? So that's the first question I always want to see, and when I examine the patient, I always want to know how much they can grasp. And then to see what position the wrist and the elbow are in. Well, the wrist being flexed like this position is actually not bad in AMC, because while most people and most people who don't have AMC are weaker with flexion, some patients with arthrogryposis and AMC are actually stronger with their wrist in flexion. And as we know, your dinner fork is in flexion. When you have a dinner fork, it's not a straight fork most of the time because it's too hard to eat with that. So it's flexed. So like the wrist, it's okay sometimes if the wrist is flexed, and I always examine that to make sure that that's not something that I have to worry about, or should I make it straighter? Then I look at the elbow. Well, what position is the arm and the elbow in? Is it very internally rotated? Is it stuck on the chest? Is it beyond that? Is it not even able to get to the chest wall? Well, then we can rotate the arm and put it in a better position. And you never want to put one arm in one position and another arm in another position. I used to hear people say, well, we'll make one arm for eating and one arm for going to take care of yourself after going to the bathroom. That is not the case. You need, especially in 2020 and especially in modern day when we use computers and we use our devices in our hands, we need to have both of our hands in front of us to be able to do that. So we never make one hand extended, one hand flexed. That we would never do. So we try to bring the arms out. That can always be done by what's called a humeral osteotomy. We can often have to break the humerus and we fix it in place in a better position. Sometimes we can avoid that by doing occupational and physical therapy, but as a last resort, we can do that. The next thing we need is we talk about passive range of motion. What motion does that joint move in passively? Meaning, what can you move it? Can you extend it all the way? Can you flex it to your mouth? And that's really crucial. So the first thing you're going to do before you even talk about muscles is we say, what is the motion of the joint? And that's going to either be the next thing we work on with therapy or the next thing we work on with surgery. We're going to get the motion, and we're never going to cast that joint. We're going to keep that joint, whatever we do for that joint, whether it's an osteotomy of breaking the bone, whether it's releasing the soft tissues, we're going to keep that elbow moving in therapy almost right after we do surgery. So the therapy plays as an important role as the surgery, because casting someone with AMC or arthrogryposis just makes them stiffer. So we begin the motion right away. Okay, so now we have the arm in the right position, it's rotated correctly, and now we have the arm moving as best as it possibly can with the joint that's available. So now we say what muscles are functioning and what are not functioning. So oftentimes people talk about the triceps. That's the muscle that extends the elbow. But that muscle is needed very often for things like crutches or walkers and things like that. And also transferring it to make it a muscle that actually flexes the elbow almost never works. It's never strong enough. So I would say I never transfer the triceps to make it a biceps. I never transfer elbow extension, straightening, to make it able to flex the elbow. But there are two other muscles that can be used to flex the elbow. One of those is the latissimus dorsi. That's a muscle on your side. It's really evolutionarily used to climb trees, which we hopefully don't do much anymore. And basically we can use that from the side, and if it's available, we take it and we transfer it and make it into a biceps. And I've been very successful in doing that. There are some videos on my website that you can see where I've taken that muscle, before and after pictures, and if they're not up there, I'll make sure that we have some videos up there this week that show the children or adults or adolescents that I've done before and after the surgery of taking the latissimus, which you don't need, and making it into a biceps, which makes your elbow, the child able to eat, or the adult able, or the adolescent able to eat. There's another muscle called the pectoralis major muscle, and that's your chest muscle that you can use also as a biceps, and with some very good success. I haven't done too many of those because of the scar it leaves on the chest wall, and so I've tried to avoid that mostly in women or in girls because of the large scar that it does leave, but it is a good functional muscle to use. The third muscle that can be used, and I just saw a patient, I think in Arkansas, with telehealth on the phone with this, who had it actively, had no biceps, but was able to use a forearm muscle that could be brought up into the humerus and used. If they have the forearm muscle called the brachioradialis, it could actually be used as a biceps, and it actually works very well. And that's called the Steinler procedure. And that I always look for that as my last resort to gain biceps, because I do think being able to eat by yourself is a very important function. But even if you can only regain the passive motion from full extension to the elbow moving freely, even if you don't have active, individuals find ways then to be much more functional. They can lean their arms against the table, and they can find ways to eat or do things in front of them. So I think there's a whole range of muscles and ideas that we have now to increase the motion. But what I can warn people about is don't cast in flexion if you're stuck in extension. I mean, if you're stuck straight, don't cast your elbow being flexed, because that's just going to make it too stiff. So basically just get right into, if you're going to do surgery, get right into motion. Get right into motion with therapy. They'll get as far as they can, and then surgery if needed to help the therapist even increase the motion even more. So there are a lot of available ways that we can utilize to increase our motion, and that's my theme of 2020. Increasing the motion in AMC. That should be the thought process, not just making straight joints. Arthrogryposis means stiff joints, and the treatment, people, whether they're therapists, whether they're surgeons, whether they're physiatrists, role should be to increase the motion. Okay, I'm just going to go through some questions I'm always asked about this. Can you use a muscle from somewhere else and put it there? So my knowledge is that we can't yet. You can't take it from the mother or father. Always want to donate one muscle and put it in the arm. But perhaps someday we can take it from, let's say, from the leg and transfer it with its nerve and artery into that and then make it function. Certainly I'm looking into that. And if there's anybody out there who's watching this who is doing that, a surgeon or a surgeon out of this country who's doing it, I am certainly willing to listen and see if that is going to be the next possibility. Because that's the brave new world, right? Taking something like a gracilis muscle from the leg, which is a hamstring we don't need, and make it into a biceps. Love to do that. So if someone out there is doing it, I'm certainly willing to listen if you have results. And certainly we'll be looking into that over the next years when I can travel more and see, there are some microvascular surgeons outside this country who are doing some very interesting work. So perhaps we can join up and see if perhaps that is the brave new world of taking a muscle from somewhere else in the patient's body and making it work in that way. So, but for now, that's not a possibility. But I do think we do have great possibilities with the upper extremities. The lowers, I'm telling you now, that has become truly magnificent, I think, what we've been doing. The feet, I think we're getting there with the feet. So the joints and even the backs, I think we know how to treat that. So I think we are really coming together now, and really I want to work with other surgeons and other physicians as well to make this happen. We're working right now on having a 3D course where it's actually going to be a course that people can be able to watch in virtual reality. And perhaps that's the next step where people can't travel too much over the next year or so. So I leave you with wishing you all a great July 4th, and hopefully next July 4th we can both be together, maybe even hug and shake hands, and perhaps even socially not distance from each other so we can once again be human. And I really do miss my patients and people I meet at these conferences. It gives me great strength to continue this. And I cannot wait to once again join you in person to have these meetings, whether that's in South America, in Peru, in where we're supposed to be in Arizona, wherever in the world, in this country it brings us. I think we'll get together and create new ways of treating this condition and supporting each other and supporting the world in this condition. So I wish all well for the Arthrogryposis Awareness Day, which is coming up on June 30th. I will wear the appropriate color that day and hope you are all well and stay safe in these times that we are all living through together. Again, happy July 4th and have a great summer. Take care.